Welcome. The American Association of Neurological Surgeons is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The AANS designates this live activity for a maximum of 1 AMA PRA Category 1 credit. As a provider accredited by the Accreditation Council for Continuing Medical Education, the AANS must ensure balance, independence, objectivity, and scientific rigor in all its sponsored educational activities. The content of this activity is not related to the products or services of an ACCME-defined ineligible company. Therefore, there is no opportunity to insert bias due to financial relationships. Credit claiming will be available in our learning management system, NeuroU. Claiming instructions are on the screen and will be shared again at the conclusion of this webinar. By the end of next week, participants will receive an email notification of enrollment to claim credit. This notification email will also include instructions on the screen for your convenience. For any issues or questions claiming credit, please contact education@aans.org. Now, to get us started, I would like to introduce Dr. Zerlup.
Thanks, everybody, for coming. I think this is going to be fun and hopefully informative. This is the AANS CNS Tumor Section webinar series. This is specifically part of the series on spine oncology. And today we're going to discuss pearls and pitfalls on how to start a spine oncology program. Specifically, spine oncology has kind of historically been kind of a round peg in a square hole. Like there's lots of different ways to get into spine oncology, through spine, through oncology, and a lot of different skill sets that people pick up all along the way. And then depending on your different skill sets, there's different ways to set up a practice. And so I think hopefully we have 3 people that have set them up probably a little differently, but a lot of the similarities. And we can talk about all the different ways to set up a practice and then hopefully open it up to discussion. So I'm just going to introduce myself, and then Ahmed and Dr. and John are going to introduce themselves and kind of part of their training specifically and their journey. And then we'll go through a whole bunch of stuff. So my name is Nick Zerlup, and I trained more from the oncology side than the spine side. I did a 2-year fellowship at NIH in the lab and doing like von Hippel-Lindau stuff. And then I did another 2-year fellowship at Memorial Sloan Kettering doing cranial neuro-oncology. And part of that was a postdoc in a lab, so more from the science lab side. And then actually started out in neuro-oncology cranial and then slowly switched to spine oncology after only doing like basically a few months of it at Sloan Kettering, and then caught up in learning the spine part over the years, but have a good background in radiation and then the oncology part. And I'll let John and Ahmed tell you how they got here.
Sure. So hi, everyone. Thanks for having me. It's great to see you here and for joining us. So I'm John Shin. I'm currently the head of spine surgery here at Penn Medicine, University of Pennsylvania, and where I am very involved in sort of clinical spine surgery, and I have an interest in all aspects, including spine tumor and spinal deformity surgery. By way of training, I did my spine fellowship at the Cleveland Clinic. That's really where I started to develop an interest in oncology, working under great mentors like Ed Benzel, Mike Steinmetz, G. Krishnani, and I had a little bit of a different path, so I was there for 2 years. The second year as a fellow, I took a lot of time to spend time with the radiation oncology department, specifically John Su and Sam Chow, as well as Lily Angelov, who's a cranial neurosurgeon, but had a lot of expertise in spine radiosurgery. Not to age myself, but this was back in 2010. So at that time, stereotactic radiosurgery was really kind of becoming part of these spine oncologic programs. And I saw that as an opportunity to, while I was there, to dive deep and learn something about radiation, because before that, it was all about pedicle screws and whatnot. And so I spent a year doing that and also doing cases and writing and doing research. And then I started my career in 2011 at the Mass General in Boston. I was there for 14 years. And during that time, had a wonderful time collaborating and really helped amplify and build upon the spine tumor program there. created a scientific program, as a research program, as well as a clinical program, collaborating with orthopedics and colleagues across the cancer center. That was really great. And then started at Penn just about a year ago. And so I'm excited to talk to my colleagues here and learn from each other and share our journeys. And I think there's a lot that we can get into. And so thanks everyone for joining us tonight.
So my name is Ahmed Moise. I feel like my story is gonna be like, yeah, I played JV basketball as I'm in the shadows of Larry Bird and Magic Johnson over here. But basically, I'm a Jersey guy. So I did my training at Rutgers, and then my research year I spent in a basic science lab doing GBM research, but I also became essentially a radiation oncology resident. So I spent solid 6 months doing plannings, treatments, and understanding how radiation interplays with cancer, neuro-oncologic cancer. And it was during residency that I really enjoyed neuro-oncology, but I started to gravitate towards spine. I just loved the complexity of not only the destruction a pathology can cause, but the reconstruction that we have to provide. So I was blessed enough to get a spot at MD Anderson after residency, and I knew I wanted to focus on spine oncology. And the way the fellowship was set up, you did 4 months of skull base, 4 months of cranial, and 4 months of spine. But even when I was on cranial skull base, I would, ask my co-fellows who may not have an interest, hey, do you mind swapping cases? And during that, I tried to understand not how do you put a pedicle screw, right? Because time you're a fellow, you should know, but what is our role as a neurosurgeon who, spine oncology surgeon? What is our role in collaboration with the oncologist, radiation oncologist, and how do we get the best outcome for the patient? And it was through that and understanding the interplay that after fellowship, my first job was up at Albany Medical Center where I am now. And the task and what I told them I would do is build a spine oncology practice. That is my passion, and that is what I want to do. And I was fortunate enough through each part of my training, fellowship, and things like that to get the tools in order to build. And I think, that it will segue into what we're going to try to do today is each one of us elaborate on what is the tools, what do you need in your toolbox to build as you go through your career.
Awesome. And I think there's the common theme between all of us is the oncology and the radiation background. I did also 6 to 8 months of radiation oncology and wrote many radiation grants, all unfunded, but thought about it a lot. But it's one of the few. I mean, all of neurosurgery is becoming more multidisciplinary, multi-collaborative, but spine oncology is key, is the multidisciplinary aspect of it. So having those collaborators and the multidisciplinary people that you work with is super important. And you can't build a practice without having them. So John, how did you, because you went from MGH to Penn. So when you went there, how did you make sure that when you're going there, you were going into, who did you contact and say, we're going to build this program together? Kind of, did you do that, or you just showed up? I mean, you have big names. You just showed up and said, let's do it.
Yeah, so it's very interesting, and I think that whoever is on or is going to be watching this, depending on what phase of your career you're at, I think you'll get something out of it. Because when I started at the MGH, I was coming out of fellowship in Cleveland, and so you're obviously stepping into the arena as a very junior person, right? You've got aspirations, you've got this great training, but you're literally entering the arena, right? And so you've got a lot of seasoned gladiators there, and you don't know what the culture is, and there are a lot of dynamics. And so I'll share a little bit of that, and then I'll talk about my experience now shifting to Penn, 14 years into practice. And so when I started at the MGH, I spent this time at the Cleveland Clinic where, to me, it was like spine heaven. It was all things spine, and then we had radiosurgery. And we used various treatment devices. And at the MGH, they were really well known for protons, but did not have a SBRT or spine radiosurgery program. Did not exist. It was pretty incredible, right? So everyone was getting fractionated radiation or protons. And so that was an opportunity. And so I had to, at an early phase of my career, at a very junior phase, start making alliances, right? Start trying to feel out, hey, who am I going to partner with in radiation oncology? Because I looked at other places that I wanted to emulate, like my colleagues at MSKCC or MD Anderson. I said, hey, they always had this great partnership with neurosurgery and radiation oncology. And it just turned out a great junior colleague in radonc there, Kevin O, and said, Kevin, let's build this, let's start this. And so we actually we started the SRS program there in like 2012 from scratch, right? And so that was a huge opportunity at that organization, institution. But you sort of had to change the culture and win the hearts and minds. And so there's some inertia because everyone's used to treating, let's say, with conventional and even on call. I remember there were cases when I'm like, oh, I'm going to do separation surgery. Let's team up for SRS. But the radiation oncologist on call wasn't aware that we started the program, or they're used to fractionating or just treating 8 gray in one fraction. And so there was a lot of sort of unrealized maybe tension and growing pains from saying, hey, like, I know what separation surgery is. This is what all the giants talk about, and this is what we train on. But then how do I actually execute that, right? At this hospital? Like, we have the tools, but I can't actually get people to buy into that. Like, how are we going to do that? And so that's some of the growing pains, but there's some strategies for that. I would bring in experts to give grand rounds, but then I realized I actually didn't need them to give neurosurgery grand rounds. I needed them to come in and give like radiation oncology grand rounds. And so that's what I did. I invited colleagues to come and to really infiltrate like their own village to say, hey, this is really important, and to start sort of winning people over and changing the culture of practice. And I think slowly you start building these alliances, and the importance of the multidisciplinary teams, I think, is so critical. And I'll just fast forward then coming to Penn, whether it's for metastatic disease or for primary tumors like chordomas and sarcomas, it's all about trying to find those colleagues and the teams that are going to do just that, collaborate. And I think it's understanding like who has that shared vision and purpose. And I think an easy way to start teasing that out is by going to tumor boards. You know, we had to start that at the NDNGH, but at Penn, they already had a pretty robust tumor board. And so I was very happy just to join that and to learn from others, to get a feeling for what everyone's expertise was. And so I think that is a great way not only to build community, right, but to really identify, hey, who am I going to work with? And that translates to, hey, I've got a big case coming up. Who do I need from thoracic or plastics or, ortho-oncology? And even being here for a year at Penn, we've done a lot of great work, just doing that, just sort of building those relationships. So I think the relational aspect of that is not something that we necessarily emphasize in our training, especially in neurosurgery. But I think in the field of spine oncology, I think the multidisciplinary aspect is so critical.
Yeah, I feel like, John, you and I live parallel lives. So I have the exact same, I came to Michigan and they said, I said, I'm going to come there and build a spine oncology program when I was young. They're like, well, we don't have any spine oncology here. We do about 20 cases a year. And so I got here and then ran into a Sloan Kettering rad-onc grad the same day at our orientation. And then we said, let's do this together. And you really, really need, if you have to pick, there's a lot of people that are involved in a spine onc program. Neuro IR helps, physical medicine rehab, plastic surgeons, as John said. But rad-onc, you cannot do it without rad-onc. So to the younger people, if you're going to go take a job and you don't have rad-onc buy-in, it's going to be an uphill battle. But like John said, I brought in like Mark Bilski to come give grand rounds, and the oncologists, and oncologists really want to see that you are like looking at the science. They want to see the science, that you have some science. So they always like, you can win them over with that if you have some scientific kind of insight and to do that. But you really need to build it and as a multidisciplinary program. But the oncologists are the key, the radiation oncologists are the key, and building the science we can talk about later. And that was, I think, again, very parallel to John's in an academic institute. So Ahmed, you have a little different setup, and yeah, you might have run into even more pitfalls when you started.
So like you guys, I'm in an academic center, residence, and whatnot. The difference is the hospital setup is we don't actually have our own oncologists. We're partnered with a place called New York Oncology Hematology. It's a private group that we're contracted with. And our radiation oncology department at the time was 2 people that are hospital based. NYOH has its own rad onc, biggest oncology services out there. But we had only 2 rad oncs. I quickly went to 1. Obviously, coming here, the first thing I did was meet the radiation oncologist here, explain what I'm trying to do. They had never done SRS or SBRT. They were doing it conventional, and talking to them about what I need help with. And really, I was at their mercy, right? Because without radiation oncology, and it's going to be the theme, you can't really move forward. So that was one aspect. And the other aspect was getting that private group on board with what I was trying to build, right? And so when talking to the oncology group, the private oncology group, the thing was building a better oncologic communication and practice with this hospital. And I asked them directly, what is it that you see as the biggest detriment to this relationship growing? It's like, well, in the past it was communication. And it was, okay, easy. Here's my cell phone number. Boom. And every time I see one of your patients, I will text you. I will call you. And they appreciate it tremendously. And then it was, hey, I want to do spine oncology. And then it was the education, right? The bringing the people in, as John talked about, Nick, as you talked about. And then ultimately it was about putting your money where your mouth is, the outcomes, them sending you that patient, you performing the surgery, understanding, hey, this is the reason why we shouldn't just do radiation. We do separation surgery, then radiation. Them seeing that, hey, that actually does work out better. And then trying to create a line of communication where they may see a patient at another hospital in their office. Hey, I got this patient. Do you have a minute? 6 p.m. on a Sunday. It doesn't matter. What do you think? You pull up the film. I think I should operate and then you should radiate. Okay, when can you see her? Tomorrow. Doesn't matter. You double book yourself, right? That's the services with the ultimate mentality of the outcome is we're trying to make this as painless for the patient as possible and give them the best chance to kick cancer's butt, right? That's the ultimate goal everyone has. So in developing the relationships, I didn't have the setup within the hospital. I kind of had to bring it to the hospital, if you will. Then we started to do the SRS in the hospital where there was more comfort and the explanation. Then we started to do stereotactic and separation surgery and go to when they go to the private hospitals or whatever. And then the buy-in was the big private oncology group, NYOH, the other private practice radiation oncology groups that cover other hospitals, and that hub and spoke model, kind of creating it yourself where you will be the hub of expertise, if you will, but really you're just taking the knowledge that you've gained from going to conferences, talking to colleagues, spreading it to others, and then they will then come to you and be like, let's have a discourse on this. And sometimes the answer is no surgery. Sometimes it's, okay, it's just conventional, just biopsy, whatever the case may be. So many times one needs to realize some of the consults you're going to get, some of the patients you're going to see don't need surgery. And that's okay, because you're developing a relationship with the other providers to say, let's collaborate. It may not be in the same physical space. It may not be in the same hospital. But if you can make the community smaller and become that hub of knowledge that you can spread to others, and that line where patients can come see you, you send them back to the radiation oncologist, you communicate. That's kind of what I had to build here. So there was no spine oncology. They did 36 cases the year before I came, right? And then it was, yeah, go build it. We just they're like, we don't know how. And I was like, you know what? I don't exactly know how, but we'll figure it out. But the radiation oncologists were the keys, honestly.
And I think that goes a lot to what John and you're saying is, you got to be available all the time. We'll talk about how to get referrals a little later, but you got to, I felt like the oncologists really, once you become someone they can trust, that they can say, I don't know what's going on. I just want to, they see a bone met now, they just transfer to me, like, oh, go see our neuro-oncology, our neurospine oncology. But that does mean I probably get 4 to 5 consults a day. I guarantee I don't get more than 1 or 2 surgeries a week. There's the predominant number of consults you get is non-operative, but you're there. And as a lot of surgeons want to just operate, but you got to understand, as a spine oncologist, you're an oncologist too, and you're providing a service to all these other services and the patient. We get in, a med onc won't see a patient until they have a diagnosis, but we will. So we get all the patients sent to us who have just a bone lesion. We arrange the biopsies, we get the diagnoses. So everyone is just shoveling everybody into your door after a while. And that's the thing you want to build, but it does take some time and some setup. So my next question to both of you guys is clinic. So, Sloan Kettering was very multidisciplinary. They had radiology, interventional radiology, rad onc, neurosurgery. They didn't have oncologists because it's hard to get oncologists in. How did you guys set up your clinic? Is it truly multi-D? How many different specialties are in your clinic? And how much surveillance do you have in your clinic as well?
Yeah, maybe I can kick off with that one. And this one, I don't think maybe it'll be controversial, maybe not, but I have actually found multidisciplinary clinics not to be that effective. And I know it may work in some places, but we did that at the MGH. We tried that off and on, but it's great in concept, but I think it's really hard to execute when you have really busy clinicians like surgeons and radiation oncologists to break apart that time to make that time. Because a lot of times the conversations we have, it's done. We sort of know what we're going to do based on the imaging of the clinical story, and you just need one person to really get a good exam and to really put hands on that patient and really understand, are they having biologic pain, mechanical pain, what are they going through? So I've seen a lot of different models with that, and I don't know, I think if the structure of your practice and your cancer center or where you are in your community, it works for you, then I think that's great. But I think for us, it was a little bit of stop and go. And with regards to that, just because we would have our tumor board, and then we'd have all these discussions on email, and then it's sort of like we already kind of knew where we needed to go, and sometimes it was just very difficult to get people all together at the same sort of physical place. And I think that COVID changed things a little bit, just with us learning to adapt to more sort of virtual platforms and realizing we all just didn't need to physically be in the same space. But I'm curious to hear and learn how you guys do it, and or how you're thinking about doing it, so.
Yeah, so when I started, it was COVID, so you weren't allowed to have one person, closer than the football field away, and if they sneezed, you'd have to isolate and basically burn your skin for 6 days. So there was no collaboration, right? So, and again, it would be it would not be possible because I'd be collaborating with people who technically don't have a clinic here. So, John, like you said, COVID changed it where we realized we could use Zoom, we can text, we can FaceTime. It may not have to be in the same physical space, but what happens is sometimes I'll get a referral from a rad onc, what do you think, or an onc, and I call them, hey, where are they in their treatment? What happened here? I just need that information. Sometimes it's in the notes, but then I'll call and be like, hey, just to follow up, you're worried about instability in this patient. Really they're complaining of biologic pain. I don't think they have instability, low SIN score. I think you can just radiate. If something happens in the future, we can take care of it, but I don't think that they need any surgery now. ideally, at MD Anderson, there was a collaboration clinic. So RadOnc and us had a clinic together. John, as you said, there is some practical issues where if you're running, like your clinic's busy, you're jumping between rooms to come to a complete dead stop to talk and then try to catch up becomes difficult. Sometimes you're just running boom, 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 boom. And at the end of the day, you're like, okay, let me go talk to the RadOnc and ONC about these patients. So I feel like there is a certain point where if you get too busy, the collaboration becomes more detrimental than moving forward. But I think the key, I think the definition of multidisciplinary or multi-collaboration changed where it may not have to be the same physical space. As long as you communicate in a certain setting about the patient, be it before, be it after, during, the idea is you're getting all your ideas together to come with the best outcome. So, for the people who are interviewing or looking for jobs or trying to set up, if there's no physical multidisciplinary collaboration, that's, I think, meaningless at this point in time, in this day and age. If you could set up a tumor board before, tumor board after, discuss during, texts, emails, phone calls, that is multidisciplinary, multi-collaborative. You're doing it without having the same physical office space, and that's okay. But I think that, what we all say is it's team. The alliances, the collaboration, the relationships, you're bringing that on, and it'll be natural. It'll just be part of it that you are doing it, without what used to be, the same, 3 clinicians go in and talk to the patient at the same time kind of thing.
Yeah, we kind of have a hybrid at Michigan, where, we have a dedicated one morning a week of multidisciplinary clinic, but, a lot of other patients are being seen outside of that. But we do have it where just radiation, I see it. And then we usually email the oncologist and tell them our plan and ask them if they have any opinions on it. Do they want to do this or that? So we kind of have a hybrid, but obviously RadOnc sees patients without me and I see patients without RadOnc because we want to see them faster than just once a week too. So there's certainly, we want to get them in quickly. I think that there's the advantage of the multidisciplinary clinic for me is that there's a lot of buy-in from the rating onc, like, especially if you're just starting out, it might be nice because then like they're going to make sure every referral goes to you from radiation oncology. Like, we used to have clinic in radiation oncology. They would see me down there. And then, if you're competing with other neurosurgeons in the area, then you're going to get all the referrals because they're like, they know you, right? Like, and that could be virtually, or it could be like, but I was if you're with them and in their minds, then they'll send you the referrals. So I think there's buy-in like that, but obviously sometimes I think the patients like, everything just at once and then they don't have to go to another physician. But again, I think with the whole Zoom thing now, you don't necessarily need it because we have virtual tumor board. We don't have tumor boards. We just talk to the oncologist because normally every tumor board, we get an oncologist that doesn't know the patient and they're talking about something else. So I think it's, as Ahmed said, it's easier just to call the oncologist up and keep that line of communication open. So I think multi-D clinic is I think it's good, but not necessary. And can be hard depending on your setup. And it can be virtual or in person. So.
No, that's a great point. And I think something, because we're talking about sort of like how we did things or the challenges that we faced. And, we learn also, you have to learn your environment, like the practices, how the radiation practices are, the med-onc practices are. And one thing I realized was that, we didn't have many people, let's say at the MGH, who had expertise in SBRT spine. We really had one, then 2, but we had a lot of radiation doctors who could deliver fractionated conventional radiation. And so we had to think about sort of the operations, sort of like the flow of patients through the system, as well as where the patients are coming from, because this is something that I don't think many trainees in neurosurgery will realize maybe once they step outside the confines of their residency, because you're not really paying attention to like practice and organizational dynamics. You're really just thinking about sign out, OR, post call, and whatnot. But the reality is in a lot of cancer programs, like the radiation oncologist in a disease site, like thoracic center or the breast center or the myeloma, like that radiation person will treat bone metastases, including the spine. And they may treat fractionated or single fraction or not SBRT. And so because the med onc, if there's a question, they will reach out to the radonc person likely first versus to a neurosurgeon. And so it's understanding that communication pathway and then creating relationships with the radiation doctors in each of those disease entities, I found very effective, right? So for me to get to know the radiation person who took care of like the GU cancers, the RCCs, melanoma, lung, prostate, it was great because we just had a great working relationship. And when they had a question, they would just come to me, right? And so I think that's an opportunity where you just have to understand, like, hey, where are these patients coming from? And because I would wonder, it's like, well, how come I'm not involved in any of these sort of email chains and whatnot early on, But then you develop that. So Ahmed.
Yeah, John, you bring up a really great point, and it's something you said is understanding the organizational structure in where you're at. So if someone goes and forces their will in terms of it needs to go like this, I guarantee it will not work. So the first thing to do, everyone after fellowship, residency wants to hit the ground running. I'm going to go meet this. This is how we're going to do it. This is the blueprint, but it's like, take a step back and, like you said, just see how things are flowing. See where things are falling through the cracks or maybe not, or where you can optimize, and then go from there, right? So an example would be if I came here and I said, I demand a multidisciplinary clinic in my office. This is the only way it'll work. It was doomed to fail. So I had to understand how cancer patients get here, how referrals get here, who's communicating, who's giving, like you said, the SBRT, who's giving the conventional, who's doing the bony mets, things like that. And then, like you said, that it was a plug with the radiation oncologist. 9 times out of 10, I guarantee the way consults happen, and what I've learned is oncologist gets a phone call from the ER, your patient's here, back pain, we got an MRI, there's a MET to L3. The natural progression typically is they call the radiation oncologist. Hey, I need you to radiate, there's a tumor. But developing that ratio with the rad-onc goes, hold on a sec. Let me just get an opinion from my spine surgeon. And they call. That's 9 times out of 10. So, and 1 out of 10, the oncologist will call you, right? But I got to tell you, it's usually the rad-onc because they get the first phone call. And so plugging that in. So taking a step back wherever you start, understanding the workflow, understanding the organization you're at, what it provides, what it doesn't provide, optimizing that segment, and then ultimately trying to be the next phone call, right? So the first phone call goes to, if you get the first phone call, great. It usually doesn't happen. Sometimes it happens, but trying to be in that phone tree where you're going to get that phone call. And like Nick said, FaceTime, just go meet them. Oh, what are you doing here? Just hanging out, man.
Yeah, I mean, I gave so many grand rounds when I first started, and not like, some of it was algorithmic and how to treat spine onc patients, but some of it was like data driven because that's what they want to hear. And then at the end, hey, by the way, we're running the spine onc program. If you have any questions at all, here's my cell phone, just like you said. Call me anytime. I'm happy to help with any patient. And then it's not going to be immediate. Like, we started, they were doing 20 cases a year. And then it went up to 30, and then it went up to 40, and now it's up to 90. It's like, so it takes time to build a spine onc program because you have to gain the trust of so many people, because there's so many different oncologists. There is the myeloma oncologist there, if you're at a big center. There's so many different radiation oncologists. Like John said, you got to know the head and neck guy. You got to know the bone guy. You know the GU guy. So it's just a lot of people to meet, talk to, and gain their trust. But the more available you are, as availability goes for sports and neurosurgery, right? Like if you're available, that's the best ability is availability.
And the
No.
knowledge base that, and Nick and John, you said it both, is we're not just, and this may sound weird, we're not just spine surgeons, right? We understand the radiation, how radiation interplays, conventional, fractionated, proton. So I would strongly urge anyone listening, anyone wanting to do this, understand you don't have to be an expert in everything, but don't think that I only do spine, therefore I only have to understand spines. No, you have to immunotherapies, different radiation modalities. It'll make you a better doctor because cancer is more complex than, just spine, if you will.
Yeah, these are such great points. And I just want to build upon something Nick added before, is that I did the same thing. I gave a lot of talks, not just like fancy grand rounds, invited talks here and there, but really like grassroots level. Like I gave talks to med-onc fellows, radiation oncology residents and fellows, 6 o'clock in the morning, whatever, because they needed like education, but they also wanted to know like how to pick up on horrible mechanical pain. What are signs of cauda equina compression? What are signs of spinal cord compression? And over the years, as soon as I would do that once or twice a year, each academic year, get to know them. These are the ones taking call. These are the ones in clinic with their attendings, whatnot. That can be very effective. So I think we're talking about building programs. Yeah, what are some of the strategies to build that community, right? So one is giving talks outside of neurosurgery, get out of your echo chamber, right? Start meeting other people, right? Get out of the OR. You have to meet other people and build that network, especially since we're emphasizing the multidisciplinary team. And also build your own team. Like we have amazing APPs, nurse practitioners, and when I was in Boston, it was great for my APP, Christina, to like get to know the APPs in all the disease sites, right, including radiation oncology, so that people communicate with their peers, right? And so it's like, hey, we saw this person in clinic, they've got this thing, we don't know if it should get kypho or not. The fact that they're calling you or thinking about calling you is great, right? Because you've already, like Ahmed said, you've established that chain of communication. And another strategy that I employed early on, I still do this to this day, whether it's a primary tumor or a metastatic tumor, because it's all multidisciplinary. After every case, I'll email the entire sort of treatment team, right? And says, hey, surgery's done, everything went great. This is what I did. This is what I anticipate. We did separation surgery. I'll even throw in nuggets like, hey, I cleared away all the space around the cord, whatnot. And I realized that everyone appreciated that line of communication, right? So you do that once, twice, you do it 50 times, 100 times. Now you've got a program because you've identified sort of like you're responsive, you're available, but most importantly, you embrace and you accept that responsibility to that patient and being part of that team, right? So I found that personally, professionally, very fulfilling and actually very effective in terms of making people aware that, hey, I'm finishing this case at 10 o'clock at night. I'm emailing everyone like that patient's being wheeled to recovery. Hey, everyone, we're done. Thanks for all the engagement. I just want to communicate. I think they'll be ready for radiation in 2 weeks. We can start the sim planning, whatnot, and everyone's on board, right? So we don't have to wait for a clinic. Don't necessarily have to wait for tumor board, but hey, we're starting, and having that open line of communication, I think, is very effective. And with the grand rounds too, just came to mind, palliative care, extremely important. So have created great relationships with palliative care. That really goes a long way, because not only do they advocate for the patients, but they're always there and they can be a great resource. And once they understand like what it is that we do and how we complement the multidisciplinary aspect of the oncologic care, I think they can be very powerful collaborators, allies, and advocates, So it's not just about, oh, these surgeons just want to operate, I think the empathy and the understanding really comes through.
Yeah, I think that, you know, the ones you don't operate on give you the more credibility than the ones you operate on when you first start. You know, when the oncologist asks you a question, you're like, you know, I don't think we need a big surgery. I think they just need a little bit of cement and they'll be great. Or I don't think, you know, with this prognosis that they're going to get a benefit from surgery. They're probably not going to leave the hospital. They may die. Let's just radiate them. And if you understand the oncology and, you know, work the algorithms basically, and I think they really appreciate that. And then, you know, like you're not just a surgeon who's going to do some 360 corpectomy cages, 5 up, 5 down type thing. They're going to give you their patients more. And I still do the radiology, the resident talks to the, you know, the radiation residents and the oncology residents. Because, and again, as a neurosurgeon, you have a different perspective. Like myelopathy is missed a lot by other non-neuro people, because, you know, the guy comes to the ER, they don't walk the patient, so they miss this all the time. So we talk about that a lot. So, but giving those grassroots talks, like Don said, I think is totally key. And you got to do it in a way that obviously doesn't come off on like, I'm not telling, you know, you always got to do it in a way that's not egotistical, so to speak. So, but I do love the circle back all the time. I try and do it, probably not as good as John is at it. But it does. I always, we're getting these emails at midnight from other people. Like, is this guy really up at midnight doing this? But it's always good to show that you're putting the work in. So.
One also way to jump on the grand rounds is if you try to also reach out to other hospitals, is each hospital typically has like what they call like a physician liaison, and is find yours in your hospital, wherever you know the residents, fellows ultimately land. Because you know there may be other hospitals in the surrounding community that are not part of your health system that may be sending patients to other places that are further away than you being down the road. But if the physician liaison can touch base with that hospital, because if you're lost, like how do I even get there to give the grand rounds? They may have a contact, and that's another way to open another avenue of a grand rounds to a hospital system or a practice that you may not have known. I've utilized that quite a bit, and it's helped.
And that goes to one of the QAs in one of the chats, is like, how can industry help with building a practice? Like our physician liaison wasn't very good at being able to tell me who does what in the state for some reason. But industry was actually pretty good at telling me, oh, these are the cases, these are the people that are doing these surgeries, these are the big oncology clinics and the oncology centers. And so once you identify the players in your system or outside your system, because like and probably at John's stage, when you've been there 5 or 10 years, then you want to grow outside your system. How do you do that? That's different than growing in your system. So you have to do it a little differently. But the industry was very helpful in that, in identifying outside the system players, so I could do outreach to them as well. We talked about doing, like helping, you know, and John was talking about putting in his notes sometimes, like, you know, oh, we did this in the surgery. So this goes to like when you're building a program, if you can, and again, you always have to lay the waters, and I wonder what you guys did. How involved with the planning of the radiation are you? Like when I started, we made an edict, because that was, we were able to do it, that every plan had to be approved by myself and a radiation oncologist. So because we built it from the ground up, and then we kind of got so busy that, and we had 2 spine SBRT guys. Now it's okay, 2 spine SBRT radiation oncologists. If it's a post-surgical case, the surgeon has to approve the plan, because we do have stuff to offer as far as, well, there was a little bit of tumor leaking up here, we got to cover that area. And so it's been very helpful in being involved with the plan. Less so in the billing. We're still not worked that out so well, although you can bill for this, and anybody who's building a program should figure out how to do that. But what did you guys do with the radiation plans?
Yeah, it's so funny. I'm laughing because I sort of did the same thing when I started. I was like, oh, I want to look at the plans. We're building this together. I want to look at the contours, and you know, it was kind of like the nerdy aspect of, oh, I want to see the GTV, the CTV, and all this other stuff. But the reality is, I got way too busy. You know, I mean, for me personally, and still am, like just too busy for that. And so once we really created sort of like our workflow, and you put a lot of work in the beginning, right? It's kind of like, I thought of it sort of like as a startup, right? Like this is our startup. We're like the spine oncology team. And just to go back a little bit, so when I started in Boston, We went on a little bit of a field trip, a road show. I took our radonc, some of our dosimetrists, radiobiology people, and brought them to Cleveland, spent a day, basically, learning kind of like how they dose things. We went to New York to MSKCC and spent a day there to kind of get them ingrained, right? And then we created our own formula, like our own recipe for how we wanted to do things. Program took off. I personally got way too busy doing cases and whatnot, and so I sort of had to relinquish that. But I also knew that we had understandings on dose constraints and targeting and whatnot, organs at risk, and so it was great. But like you said, Nick, I think you just work with what works best in your flow, right? And it's just for me, it just became too busy. I was needed more in the operating room, and I did not want to slow down the patient sort of experience or their treatment or timing based on my availability to approve plans or whatnot, and so but that's what I've done over time.
Yeah, so just to go on the last point, just to talk about industry can help tremendously for whoever asked that question. As long as they're the same mindset of helping patients, they can connect you with people that you may not be able to connect with easily and give you an idea of the surrounding community and potentially the new technology for whatever you're trying to do. Now, regarding the radiation oncology, so, here it was in the beginning, it was with the hospital-based radiation oncologist. I would go and just look at their plans, we go through things. And then ultimately it's building that trust where it's like, okay, go, they tell me plan is, we do it together. And then it would be, okay, plan is done. I'd review. And then ultimately it was, okay, I think you can do it. And then for the community, I actually would drive to different sites to do plans with the radiation oncologists because of the relationships, the FaceTime, and also I just want to make sure everyone's on board of what we're doing, what I did, they understand. But then it just got too onerous that, that they'd be free at this time. And it's like, I can't because I have clinic or OR. We'd meet at like 6 a.m. before I have to be at the hospital by like 7 for a case. But again, it was just about that foundation of, okay, what are you doing? What do you understand? What can you teach me? What can I teach you? And then once you build that trust and understanding of the workflow, you kind of let it go and you go back to focusing on good outcomes, being a great surgeon, and then the research and, blah, 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 as it goes forward.
I think like both John and Amit said, like when you start, you always want to be heavily involved and you can let it go as you go along. But if you're trying to sell stuff to your chairman and your department, like this is a huge revenue source for your department that they don't have because you're usually operating, right? And so some departments, and I've seen this done differently at different places, like we'll actually hire like a retired neurosurgeon just to go down and do not just the brain SRS, but the spine SRSs. So the department can capture that stuff and they'll just be down there to build the plans. But again, this is something that doesn't take up OR space. So if your ORs are full and your department wants money, like it's something that you can sell to your chairman, like, well, let's help with this radio. If you're building the program the way like that, you don't always have time to do it, but you can talk to your chairman about trying to keep those RVUs in your department at least. So, because I think that's always, if you can make money for your department, you always have an upper hand, I think.
That is true. That's the practicality of the difference in like becoming an attending, understanding how, the world works versus the insulation of the resident. That the department does look at the bottom line. What are you bringing in? What is your revenue stream? How are you building? But when you're building, what does it mean for their bottom line?
Mm-hmm. So we've talked a lot about building the clinical thing, and this takes a lot of time and effort. I think we don't have too much time left, but let's talk about building the research, because I look at spine onc as kind of a spoken wheel, not just like where your main thing and you're out in hospitals, but like I'm running the program and I want to have a bone research thing here. I want a frailty thing over here, like John has. I want, an interventional like IR thing going and angio and embo. And I want like research aspects in all of these things. How did you build the research platform? And what makes a good collaborator, and how to, like, let's get some advice on collaborations. for research.
John, you're muted.
John.
All right. Sure, I'm happy to start. So, I really thought I have this one slide that I put in a lot of my talks where I shows kind of a patient in the middle, and then you're right, it's kind of like I show all these other dimensions around it. And early on, I really felt like with each patient encounter, there are so many things that we can learn from that patient. One being, prospective patient-reported outcome measures, right? Like promise and quality of life metrics, questionnaires. So we build that into the clinic, the operational workflow of the clinic. With each patient, we were studying radiographic outcomes. So for every patient, I'm getting preoperative 3-foot Scully films, thinking about their alignment before and after. With the patients, I'm thinking about instrumentation and failures and PJK and revision and the implications for radiology. So I'm very mindful of like, okay, we're using carbon fiber versus titanium, or these are separation surgery patients. And then thinking about intraoperatively, well, what are we doing with this tissue? For years, I was like, we're just sending it to path and then it goes in the trash. Or what about the blood and the bone? And then we established collaborations with other scientists we realized had interest in the bone marrow environment and studying that. And they were starving for tissue and I was starving for collaborators. And then once we came together, they're like, oh my goodness. And I was like, hey, I can get you bone marrow from every case, including degen spine cases for controls from the iliac crest. And it was amazing. And that resulted in a lot of great publications where we looked at sort of tumor from the primary site like prostate and RCC, and then look at the spine specific and the bone marrow environment and being able to look at both at the cellular level. And so I think, I always wanted to think of the patient as like, how can we learn from each individual patient? And then the bulk of what we do, right, is clinical research, right? And I'll just share one story and I'll turn it over to Ahmed. But when I started, I remember, you're kind of like idealistic. You're like, I know the gnomes paradigm. I read everything that Mark Bilski and Josh Yamada wrote, and I'm totally bought into gnomes, right? And then I practice it, and then I realized, oh my goodness, like some of these patients actually are not maybe doing so well afterwards, or they're dying within 30 days, or the outcome's not so great. I'm trying to build this program, build a reputation, and I was a little self-aware, thinking like, oh my goodness, like what is everyone going to think, right? What is MedOnc, Radonc going to think? They're going to think this guy is just cavalier, whatnot. And I experienced that first with melanoma, right? And this goes back to a point that Ahmed made about like understanding the oncology. So I was treating a lot of patients with melanoma, and they would meet the N, the O, the M part of gnomes, right? But then I'd have patients dying within 2 weeks, 3 weeks, 4 weeks, never making it to radiation sometimes, never making it to SRS. And it was a real wake-up call. And one of my first papers that I wrote, which was a couple years after practice, was we looked at our melanoma series. And I looked at, what was their receptor status, BRAF positive, negative, and how naive were they to like immunotherapies at the time? And it was really revealing. Yes, retrospective, single surgeon, not the highest level of evidence, right? Wearing a editor's hat, but I learned a lot from it because I realized, what, there's something about the biology here I'm not understanding that transcends, are they 3 out of 5, 5 out of 5? That transcends what's their sin score, right? And is it radio resistant, right? And it was that there's something in that S part of gnomes that I really struggled with, was understanding how do we understand like their survival, and how do we understand all of that, outside of just asking MedOnc, hey, like PGY2, ask them what their survival is going to be, right? And they come back and they tell you something like 3 months, and you're like, oh, what does that mean, right? So that actually led me to really think about the S part, and like, because I would go to the national meetings, right, Nick, and I'd sit there and all the giants are there, right? So like Zio Gokaslin's already like done all this work on chordoma, wonderful illustrations, and all this, all this monumental amount of work. And same thing with SRS and separation surgery. And I kept thinking, well, like, what am I going to contribute to this world, this arena of spine oncology? And I said, really, I'm really intrigued because I'm really struggling with patient outcomes. Like, I'm really struggling with survival and optimizing that. And so I figured, you know what? There's something here in that S part of gnomes with regards to like frailty and nutrition and sarcopenia and body composition that has not been tapped, right? And so it's really my point being that it's the questions that you get from clinical practice that for me really drove the clinical enterprise. And really kind of, it was like one paper after the other, and you just build upon that because then you start asking deeper questions, right? And then you get people excited about it. You find other collaborators, whether inside or outside your institution. But that's kind of how I developed my own research career, was basically struggling with how do we do it better? Like challenging, like I thought I'm following the gnomes paradigm, but you know what? Like there's something off. And like, is it just me or like, and if it's not just me, then how can I contribute and help others understand this in a way that's not just like, oh, like we shouldn't operate on this person because my gut feeling, you know? Like trying to find ways beyond that. So I'm curious,
Yeah,
you guys, like how you approach that, or
again, I think John and I are totally parallel. Like same thing, bone marrow for the lab stuff, clinical questions. So I think for the young guys, we only have like 3 minutes left. So this could be a 2-hour webinar. Prospective databases, right? That's the key. If you're starting out, record everything, start some promise, like pros that you're going to get in every clinic patient, standardize things as best you can so that you have data on patients. And then you can start looking for years. Oh, look, like we have a huge sarcoma population. I can write a sarcoma, a large sarcoma series, more than any. Or, John had a big melanoma population. You can do that and contribute. We ended up a clinical anecdote, like patients would always ask, well, if you do surgery, aren't you going to spread the cancer? So we went and looked at that. It's like, well, do we have to increase our GTV or our treatment volume on surgery patients versus non-surgery patients? Because do we spread the disease a little? Like, you can get simple clinical questions like that from just one that you ask in clinic every day, and you can answer them if you have a robust program. So, and then the biology stuff is, if you're cancer trained, like it seemed like all of us seem to be, then you can help those biologists ask those PhDs ask those questions because you understand it. They don't just want a tissue jockey, though. You have to go with some understanding of the biology, and to be a great collaborator, be willing to give the success to them. Right? You're giving a talk at CNS with their senior author, their first author. Give away all the credit that you can, as much as you can. I can say that, and John can say that because we can't get promoted anymore. But so it's easy. Like I never need a first or senior, but for younger people, you do want to get on there. But give as much credit as you can to everybody you work with, and you'll get more collaborations.
I would say like I'm a little over 5 years out, and the best advice I got is, don't be anxious. The research will come. I think in the beginning, focus on being a good surgeon and having good outcomes. And like Nick said, record, have a database of your own patients. You're not going to have a prospective randomized trial day one of becoming attending. Damn near impossible. So if you focus on being a good surgeon, you'll get the volume, you record the volume, then you start asking, like John said, the clinical questions. From the clinical questions, the underlying thing you should ask is, and John, you said it beautifully, what am I going to contribute to this field? What is going to be my contribution? Does it have to be groundbreaking? Do you have to have a score named after you, the Bilski score, like the Malaise score? No, it'd be great, but if I don't, maybe I can contribute to understanding the people that we do operate and don't operate on. Are we doing harm? Are we doing good? How many segments should we do? 1 above, 1 below, 2 above, 2 below? The recovery time, blood loss, time to radiation. Does it make a difference? Do patient outcomes, the quality of life metric? So when you first come out, don't be anxious about getting the research out. It will come. Be anxious about being a good surgeon, making good decision makings, and having good outcomes and creating those, collaborations and relationships, record your surgeries, record the pathology as much as you can, as much detail as you can, age, whatever. Then look back as you get close to finishing oral boards and establish yourself, get more comfortable, look back. How many renal cell mets have I done? 25. What can we get from that? And then you start publishing, and then things will kind of come your way. And collaboration. So for me, yeah, I desire collaboration mostly because I don't really have a senior spine guy, and I know my limitations. And knowing my limitations, I know, okay, I can't get the volume I need now. I only have 20. But that guy, at Michigan, at UPenn, has 100. Can I give him my 20 and we can get a bigger N? We can get a better P-value. Don't worry about where your name is, right? At the end of the day, your gravestone's not going to say first publisher 20. It's just going to, people just be like, you'll just be judged. Hey, did you do good? And if you did good, then honestly, you can answer the question, where are you going to contribute, with a smile and be like, yeah, I did good.
Yeah, it's great hearing this. I'm just laughing because I think like I can identify with so much of that, because really I think, to be vulnerable for a moment, like early on, I was very self-conscious, I'm like going to CNS, AANS, or spine section, all these talks. I'm paying, like I'm not on faculty or whatever. I'm paying to sit in the front row, right? Just to be in the session, the lunch session, whatever. And I remember getting pimped by some of these luminaries, right? And thinking like, oh my goodness, like what am I going to contribute? What is that space? And I tell you, I started in 2011. I think that melanoma paper came out in like 2015 or something, 14 or 15, because I was hustling. I was building the program. I was building these relationships. I was operating all the time, doing all that, but I didn't have anything to write on, And so that you're totally right. And I think it's just, but I used to like PubMed myself and be like, oh man, I've got like 4 publications, and no, really, it's just like, oh, well, how is this ever going to happen?
Like today's
right?
doom scrolling.
Right. And so I just feel like be like so self-conscious, like, oh, I'm an instructor. It's like, oh, it's just, and so I think you're right. It's like, don't get too like sucked into that, right? Because I mean, I'll tell you from my own experience, like you just take great care of patients. You're thoughtful, you're engaged, and we face similar challenges. I think everyone's heard that tonight. And then you should be asking yourself these questions, like, how are you going to do it better, right? And that really, I think that's the great thing about spine oncology. It just fuels the research, right? It just fuels the questions, because there's so many elements that we can look at as spine surgeons, whether it's instrumentation, right? Arthrodesis, anterior posterior, right? Separation surgery, whatnot, infections, wound dehiscence, all that stuff. I mean, that's from the day-to-day hustle of what we do. So it's a great point on that. I loved it. That was great.
Yeah.
Thanks, man. Thank you.
So I think we're way over time, but so we don't have to wait time for questions. So I put my email in the chat. I'm happy to help any young people getting out there and help you build your program, and anything we can do. If you're John, the same way, we want to mentor people to build this community as a nation, but we can get big trials going, because we definitely need large national trials. It's just, there's too much heterogeneity. And so the more people we get, the more patients we get in large things, the better data we'll get, and the more we'll be able to help patients. So contact me, Ahmed, John, anytime, and with questions and anything. And again, for me, I tell everybody, if I don't respond to the email within a week, because I get like 200 a day, just email me again.
It just annoy me. Yeah, just keep going.
Exactly. It's not really annoying.
I tell people the same, just keep texting and emailing. Believe me, like I see it, but you just got to keep doing it.
Yeah. All right. Any closing remarks from you guys?
Oh no, this was great. Really, I mean, I feel like we could go on another hour, but people have lives, I guess, But no, this is really great. Thanks to AANS for having us. So I'm really grateful. Thanks.
Yeah, thank you. I'm very humbled and honored to be with you guys and to present. And it's funny. I still maybe sweat heavily in front of the luminaries, and I'll be honest, I sweat a little bit tonight. I mean, you guys are the luminaries. John, you talk about, it's funny, you transition to it, right? So it's I'm really honored to be in the presence of you and Nick. So thanks for having me. Really appreciate it.
It's fun, and we want to make all this collegial as possible for everybody. So
Great.
awesome, guys. Well, have a good one.
Thanks,
Okay.
guys.
Good night, everyone. Thank you. Have a good night.